Huh? Okay, sorry for the delay. I think partly because
My fault. I totally forgot.
Dr. Hu is extremely busy, and then I concentrated on climbing Mount Kinabalu last week, so kind of didn't exactly reminded him. But I sent him a Zoom link this morning, and he just dismissed it. Okay, anyway, welcome, Hu. I like to call Dr. Hu because
Yeah, WHO.
every time I see Dr. Hu. Okay, anyway, welcome, Hu.
Yeah, I still
proceed.
remember the joke of someone called me, then I say, who is on the line? Then he say, who is on the line? I say, who is on the line?
Okay, without further ado, let's go on.
Yeah, I think Dr. Patty, very honored to be invited in this platform. It's very nice to be on Facebook Live. So today, I mean, as a neurologist, so I'd like to share with one, which is a very common diagnosis. I mean, the diagnosis of peripheral neuropathy. So it's not uncommon that we encounter a case of diabetes peripheral neuropathy, especially with a prevalence about 25% or more in our Malaysia population. So it's very important that for us to detect one of the very common complications of diabetes. And actually, more than 50% of diabetes patients may suffer for either symptomatic or asymptomatic peripheral neuropathy. So it's very good for us to aware, and particular, we don't want our patient to be end up with amputation. So it's very early for us to detect if the patient suffer from peripheral neuropathy, we diagnose, so we can refer to someone the relevant for further management. So I would like to start a case study, so then I can elaborate on the diagnosis, the peripheral neuropathy along the way. So this is a case study. So again, practice make perfect. So we go along with the cases, so we can learn together. So there are five steps approach test as a primary care physicians. Very simple. So basically, we can classify the symptoms. Then we take a very thorough medical history, just like a medical student since the year we learn from medical school. Then we divide, we classify the peripheral neuropathy symptoms, signs and symptoms. Then we can do a quick neurological examinations. Then we can subject the patient for blood test or laboratory investigation. So very simple, 5 steps. So we classify the symptoms, then we take the history, then we can divide the peripheral neuropathy, or we try to further elaborate or analyze the symptoms, sign and symptom. Then we do a neurological examination, and we do a laboratory investigations. So I will start with the case, Mr. Ahmad. So what we know about this patient. So basically, Mr. Ahmad, 65 years old, diagnosed type 2 diabetes about 2 years ago with a BMI 29, overweight. So as you can see the picture, he's quite overweight. So he presented with extreme tiredness, and he had this burning pain over the feet, very disturbing, until disturb the quality of life. So how we start to investigate these patients? So first of all, as I share with you, the 5-step approach, which is published by Prof. Mane in the Journal of Diabetes Investigations, can be used by anyone. It's not only confined to neurologists. This is a very simple the way how we diagnose diabetes peripheral neuropathy. So we can classify the symptoms. So step 1, so we can classify the symptom, divide to acute, subacute, and chronic. So this is by duration. So from the duration, we kind of we have some idea what kind of causes of the peripheral neuropathy. So acute, we divide less than 4 weeks. So the most common causes for acute, which is infection. Most of the time in this era, which is post-vaccination, particularly in Sinovac, we do encounter a few patients with Guillain-Barré syndrome. But in the old days, before the era of COVID-19 or vaccination, we do see a lot of time is triggered by infection, Guillain-Barré syndrome. Of course, toxin. Then subacute, the duration, if the patient presented with the symptom of duration 4 to 12 weeks ago, which is inflammatory, immune-mediated metabolic causes like diabetes, usually the duration at least 4 weeks long, and nutrition deficiency, medication, and chemotherapy. If the patient presented with chronic, of course, diabetes mellitus is a very common cause, and we cannot, forget about the possibility of hereditary neuropathies, for example, Charcot-Marie-Tooth disease. So we can classify the symptoms depend on the onset. So again, acute, subacute, and chronic. Acute less than 4 weeks, subacute 4 to 12 weeks, more than 12 weeks chronic. So the symptoms most of the time are barely noticeable, which is most of the patients not really notice because the kind of symptoms are quite vague. So usually progress over the last few months, and patient may have difficulty in sleeping, tiredness, even worse. And this patient, he cannot really work properly because the symptom quite disturbing. So what is the next step? So we should recall the 5 steps. So the next step should be we take a thorough medical history. So how we take a thorough medical history? So going back to the basic like a medical school, so what we can check the symptom, we ask the duration, the type, intensity, localization, and the cause. Then we track the history of the disease, the lifestyle, family history, any consumption of alcohol or any smoking history. Taking any medication may contribute to this peripheral neuropathy, occupational history like exposure or toxin. So we should take a very thorough medical history so we can get a proper diagnosis like what in the old days, the very, very good professor had taught us how the importance of take a very detailed medical history so we can guide us to get a proper diagnosis. So any further question we can ask Mr. Ahmad. So we should take a very careful medical history as I shared with you in the previous slide. The past medical history is very important. Any medication patient is concurrently taking. Family history of neurological disease, so we can rule out Charcot-Marie-Tooth disease, very strong family history, and alcohol and tobacco consumption, any smoking, possible exposure to toxin, particular the patient occupation, as well as symptoms. So very helpful. This is probably you can take a snapshot of the photo. Will guide you a further history. Family history of diabetes, family history of peripheral neuropathy, family history of chronic disease, use of tobacco or smoking in any form, either vaping, smoking cigarettes, content chewing, or drinking alcohol. How much? How often in a month? Occupation, exposure to chemical, exposed to a toxin or heavy metal, family history or leprosy, and the list of medication on regular use. So we shall identify the underlying cause. So Mr. Ahmad had this history of pre-diabetes, then followed by type 2 diabetes 2 years ago. He's taking a metformin about 1,000 milligrams 3 times per day. He's practicing an unbalanced diet and a very sedentary lifestyle, no physical activity at all. So the next step, we shall looking at the peripheral neuropathy symptom and signs. So basically, the symptom of the sign of peripheral neuropathy, so sometimes for a patient, it's very difficult to describe. So we can use this photo, we can ask the patient to circle what exactly the site of the involvement, whether left or right, front, or involve the hand or involve the feet. So we can ask a very precise question. So the more specific, simple question to describe the symptom of peripheral neuropathy. So the ends are crawling, feel like electric shock. I mean, the bed sheet on the feet feeling painful sometimes, even though they just put on the bed sheet, they feel this very painful to this non-pain stimuli. In medical term, we call allodynia. So where do you experience the pain and sensation? So you localize the sensory involvement either on the hand or over the feet. So either one side or both sides, is it worse or not?
Sorry, wait. Can you go back to the previous slide, please?
Yes.
What, the bed sheet on the feet feels painful?
When you try to cover yourself with the bed sheet or the blanket, usually you don't feel any pain. So this is a non-pain stimuli, something not painful stimulation.
I see. So when they are hypersensitive to certain...
Yes, non-pain stimulation, something which is not even by a light touch by a feather, then patient feel exaggerated, the sensation.
So this, they always have a sensation that is altered.
Yes. So actually the peripheral neuropathy symptom can divide to positive and negative. So what we try to describe this allodynia or hyperesthesia, those are positive symptoms. So
Oh, I see.
another one is paresthesia. Paresthesia could be any different kind of altered sensation like burning sensation, cold sensation, electric shock. Those are paresthesia.
Okay.
So most of the time we try to get actually is the negative symptom, which is hypoesthesia or anesthesia, which is reduced sensation or they don't feel the sensation at all. So actually the positive symptom also consider one of the part of the peripheral neuropathy.
Pain, basically, right?
Yep.
Yeah.
This is one of the example. Yeah,
Okay.
allodynia. So any other specific questions? So in Mr. Ahmad have this burning pain in the feet, especially he lie down in the bed. So allodynia, as I shared with you, so the weight of the bed linear caused him a very discomfort. So he liked to stick out the barefoot out of bed to relieve. And there's a change of symptom. When the symptoms started, his feet were wet from sweating. So this is autonomic dysfunction, one of the complications of autonomic neuropathy, and the skin is dry and fragile because the autonomic neuropathy, feeling very tired, concomitant because of probably uncontrolled diabetes as well as this peripheral neuropathy. So what is the next step we can do after that? So we should do a neurological examination. So in the old days in medical school, after we take a very thorough history, then we should proceed with neurological examinations. So very simple neurological examination, so we can focus on the sensations. Of course, going back to the normal neurological examination, tone, power, reflex, sensation, coordination. So after we do a very simple tone, power, reflex, then we should focus a bit more on the sensation as the patient presented to you mainly sensation symptoms. So again, going back, you can do a pinprick. But what we can do actually focus. Sometimes we can use the microfilaments if you're able to get the microfilament. Very simple. It's just one filament. You can purchase online. Then if you want, if not, then probably you can use cotton wool pinprick by wooden, or in the old days or in the current. In the teaching, we still advise the medical student use the orange stick, which is with a blunted end. So vibration, you can use 128 hertz. So those are simple tests should be sufficient. So what you try to get is the growth and stocking distribution loss to the sensations. So you can ask the patient to close the eye, then you prick slowly, going up. Then until you ask the patient, do you feel something different over your reference point? Your reference point could be over the forehead and upper the chest wall. Then you ask the patient, do you feel the same after you prick here? Then you go along a bit higher. You say patient, until this level or the stocking level, then I feel normal as the forehead. Then you know that most likely this patient having a stocking distribution loss of sensation, which is a very classic peripheral neuropathy kind of pattern sensation loss.
So this peripheral neuropathy doesn't follow dermatums, right?
No. So what you can do, you can go three plane. You go to the middle, then lateral and medial. So you confirm. So this is not a dermatomal loss of sensation.
I see. Oh, I see. Okay.
So the tool and method you can use, of course, you can use some screening tool by certain questionnaire. Then you follow by sensory testing. So the easy way you can use this Michigan Neuropathy Screening Instrument, which is MMSI score, or using a VIS, which is a visual analog skill. Of course, you can use this pinprick, something like the orange stick, or visual inspection over the feet. So you can Google. Sorry, I don't have the detail of this slide because it is meant to prepare a very simple slide here today. I think I put on another slide there. So you can Google. This is a very simple screening tool. The questionnaire, so you can just follow accordingly. Then you can help you to give you some idea probability the patient may suffer from peripheral neuropathy. So with the score of 8 on the both, then most likely patients suffer from this peripheral neuropathy. So the next step, of course, you can offer some blood tests of the patient. Unfortunately, there's no blood test to confirm peripheral neuropathy. So it's more towards looking for the cause. For example, you look for vitamin B deficiency, HbA1c, the control of the patient. And so what kind of blood test you can order? Actually, something like HbA1c, urine protein, hemoglobin, vitamin B, homocysteine, examination of the eye to look for any evidence of diabetes retinopathy. So in this patient, we noted actually the HbA1c was 10.2, the urine protein was negative, hemoglobin about 15.2, vitamin B, the 12 about 150, which is normal, lower limit, homocysteine about 14, examination of the eye, so he suffered from microvascular complication of diabetes, which is also, he has this diabetic retinopathy in both eyes. So, of course, if you really think the patient may require to specialist, sometimes the diagnosis may not be just as simple as diabetic peripheral neuropathy. So, in what kind of cases which is unlikely diabetic peripheral neuropathy, you may need to refer to a specialist or general physician or neurologist. If the peripheral neuropathy progress rather acute or rapid, sometimes we do see some patients like Guillain-Barré syndrome progress very fast, or relapse and remitting. Most of the time, the diagnosis is CIDP, chronic inflammatory demyelinating disease, may need a diagnosis from a neurologist. Then we may need to start the patient on IVIG. So or predominant motor symptom and deficits could be a different kind of, causes, acute or mono, which is involve one of the foot instead of both foot or both side of the foot. So which is quite significant, but where this is only involve one side, then this the likelihood of diagnosis of peripheral neuropathy is which is not. So there's an absence of microvascular complications. So those are the caveat or something that you need to think, which is could be not likely a peripheral neuropathy. Then you may need to refer a general physician or neurologist. So the diagnosis in this patient is diabetic peripheral neuropathy and with uncontrolled blood sugar level. So again, diabetes is number one cause of peripheral neuropathy, and more than 50% of the patient develop diabetic peripheral neuropathy. So conclusion that peripheral neuropathy are actually quite heterogeneous in their clinical presentation, and the diagnosis is not always straightforward. So by that, I think I would like to thank you for your attention. So this is a kind of a very general sharing. So I would like to open to the floor for any question.
Because I'm muted. Sorry, I'm muted because the hospital called me. Okay. That's a really short talk. Okay, I want to ask you, what is this restless leg syndrome?
So restless leg symptoms, the exact cause is unknown. So basically, the patient have this symptom of hyperkinetic movement due to they have this urge try to move their leg. So it's a condition that urge to move the leg and lead to uncomfortable sensation, which is very different from peripheral neuropathy. Peripheral neuropathy, they have a very clear cut of this how to say, the sensation, which is usually have this stocking distribution loss. Restless leg, usually they have this urge to move the leg, which is very different kind of the complaint. So it's not exactly something, but it could, some patient may say it's not like how to say peripheral neuropathy. In fact, it's not. They just try to move their leg. So so you can see the patient moving all the leg and not really how to say the leg is just move because they have this urge that they cannot control.
Okay. Doctor, can I ask? Sorry. Generally, diabetic peripheral neuropathy has poor response to treatment. Can you tell us what are the treatment that we can actually give for those that have pain, which have positive hyperesthesia?
Yeah, basically in most of the guidelines, the first time actually we can start with antidepressant, something like amitriptyline. So you can start from 12.5 milligram on night or 25 milligram on night. then you can titrate accordingly. So however, the side effect is we may cause a lot of sedative or sedation to the patient, so we have to warn the patients. This is one of the very cheap and available, drug that you can use in the clinic. Of course, second line usually we may start with antidepressant. So it depends whether your clinic available of antidepressant like duloxetine or venlafaxine. So if not really available, then we can start pregabalin. Pregabalin, we can start the original, come with 50 milligram. The non-original, you start with 75 milligram BD, or the maximum dose is 150 BD. Sometimes we may push until 300 BD, the maximum dose, which is 600 milligram per day.
Okay, so Dr. Kaur's question is that they have poor response to treatment. Which is it true?
In a way, it depends. Of course, glycemic control is still very important before we emphasize on the pain modulator. So we have to make sure the HbA1c is well controlled. So most time we have to control the diabetes. Then we start with the pain modulator, and we have to advise the patient of foot care. So because the patient cannot feel anything that injured their foot, they may lead with the diabetic ulcer. Then of course we are very worried patient may complicated with amputation.
Okay. And he said that, is there anything that we can do to improve outcome? I think your answer is already there, that the only way may be to...
Glycemic control is still the most important step.
Okay.
Of course, some doctor may try to start the patient, how to say, vitamin B. So of course, we can consider some vitamin B. There are some paper published on the tocotrienol, the vitamin E may relieve some painful diabetic neuropathy. You can try on that.
Okay. Now there's a question in from Facebook. It's asked, what is the role of alpha lipoic acid in neuropathy?
There are some studies proven that this alpha lipoic acid may benefit on the painful diabetic neuropathy. So you can start on that 100 milligram, or could be up to 600 milligram a day. Nowadays, there are some vitamin B combination with this ALA, the short form in ALA, so you can try on that. I'm not supposed to promote any brand, so I just try to put. I think you're aware the brand name, that combination with this B1, B6, B12, and ALA. Of course, you can try on that. Some patient may feel the symptom relief with this supplement of this combination. On top of pregabalin, you can try on that.
Okay, there are more questions coming in. There's a Dr. Linesh asked, I would like to ask, is there any link between erectile dysfunction and peripheral neuropathy?
I think I should ask the urology for this question, but I think there should be some link because more or less if the erectile dysfunction is attributed by the neuropathy, then probably it will be some involvement.
No, I think the erectile dysfunction is more so if it's actually atherosclerotic.
Really?
Yes, yes,
okay.
Because of the blood supply.
Instead of the nerve. Yeah.
It's not a nerve problem.
Okay.
Okay.
I never encountered any patient.
I'm a cardiovascular person. Yes.
I never encountered any patient ask me they have this erectile dysfunction issue. Yeah.
Funny, yes.
Yeah.
Patients tend to ask me, but I want to ask you, this peripheral neuropathy, what is the pathology behind it all in a patient who is diabetic?
Yeah, basically it's still the microvascular complication because
it's also a muscular.
Yes.
It's also a vascular complication, right?
But it's a micro instead of
yes.
the larger.
I see. So Fiona asks, Fiona is from Dr. Kwiti. So in Dr. Kwiti asks, Dr. Lau asks, should we generally start B12 to diabetic patients for prophylaxis?
This is a very interesting concept. I think a lot of physicians have been asking because If the patient is on long-term metformin, it's not uncommon they have this polydeficiency of vitamin B because on metformin. There are a few papers have been studied about 20 plus, more than 20% diabetic patient because they are taking long-term metformin is associated with some sort of vitamin B deficiency. But the guideline never recommend, but I would say that you can try as we know vitamin B usually is not causing so much harmful effect to the patient. I say no harm, you can try.
But if let's say it is a prophylaxis and you already see the patient, isn't it better to
generally I don't practice, so I
control
not
the
sure.
glycemia?
Yeah. Yes, sugar control is still the most important, step we should emphasize.
Yes, I think that if you see a diabetic patient, control the glycemia, make sure that the patient is on a statin and bring down the HbA1c and the LDL adequately, and you probably will hinder the progression of this peripheral neuropathy better than thinking of B12.
Yeah, definitely. But I think the question is because some patients ask whether they can take vitamin B12. It's very common question that we encounter in the clinical practice.
Is peripheral, okay, Dr. Ben Manjun asked, is peripheral neuropathy due to uremia common? How should we manage it?
Actually, it's not very common, but it's one of the cause of the peripheral neuropathy. Unfortunately, there's no specific management on that. Usually, it's still symptomatic control. Of course, if the patient already start on dialysis, then they have to continue dialysis. There's nothing specific management on the uremia, the neuropathy. It's more like for us to get the cause of this patient have uremia. Most likely, the peripheral neuropathy could be due to the underlying uremia. The treatment is more or less the same. Again, the symptomatic control as well as the pain modulator, something we can start the patient on pregabalin, amitriptyline, and etc. etc.
Okay, I want to ask this question, and unfortunately, I only know the brand name, which is Lyrica. Okay.
Pregabalin.
Okay. It's too difficult to, yeah. So this drug, is it helpful at all?
Yes, some of my patients.
Okay. Now the next question I want to ask is, I read that there are many drug users actually use drugs, let's say it's cocaine or heroin, on top of Lyrica because it gives them a better high. Have you ever read that?
I think I don't know where I read this, but I never tried in Malaysia yet.
I
Have
mean,
you
you have
tried?
tried heroin or cocaine? Have you tried?
No.
So it's irrelevant to you, but have you never seen it, right? But no, I think it's too expensive for Malaysian to try because Lyrica is so expensive. But
we can start the patient on the generic, which is
oh, that's
easily
generic now.
Yeah, pregabalin, but you only come with 75. The original come with 50 milligram.
I see.
Yep.
Because it's apparently very cheap. Okay. Any more questions? Okay, if not, let me just do the sharing of the slides. Okay. Ayo. Today very kalang kabut.
But yeah, this is the first ever faster preparation I can. 5 minutes then I can on the present.
Hold on, now where's my CPD point? Okay, hold on, let me just try again. Okay, so I've opened this. Okay.
I think I can share a summary of the
okay.
After that. Yeah, after that.
Okay, then you share the summary first, lah.
Just 1 minute.
Okay, let me just not share this. Stop share. Okay, you share the summary.
Can you, yeah, this is a summary of the management. Yeah. Then the opioid is second line actually. So you are not wrong.
Sorry?
Opioid like, yeah.
No. What I'm trying to say is, no. My question is actually that, do you think it's true? Because a lot of people who take the opiate, or let's say cocaine or heroin, the drug user in US, they actually take it with Lyrica to get a better high.
I think quite interesting. I think it should
Yeah.
work from
I
the
just
pharmacological, yeah.
I don't know how it works, but apparently it does. Okay, so yeah, go on with your what?
So basically, this is a summary of the management of painful diabetic neuropathy. So this American Family Physician 2016
Okay.
CPG, I think it's a very simple and straightforward. So if you already encounter any patient in your clinic, so you can consider first line therapy, second line therapy, and third line therapy if the drug is available in your clinic. So those are very simple way we can manage this group of patient, which is not uncommon we encounter in our daily practice.
Okay, now my question is, let's say they already have established peripheral neuropathy, and we manage, is it related to their glycemic level?
For our experience, some of them the symptom may partially, better after the glycemic control. Unfortunately, there are certain group. I think it's probably a bit quite late after you try to, even the damage has been done, so it may take a longer time for the nerve to be recovered. So yeah.
So I always thought that it was related to the glycemia level.
Yep. Some patient may we have the paper that reviewed that actually after glycemic control the symptom was better.
Better.
Yep.
Okay, Dr. Koh has a question, and he said, from your experience, do they actually improve with treatment? I find the answer extremely disappointing.
I totally agree with him. Agree. Yeah.
You mean he found that it does not improve with treatment, is it?
Sometimes I use a combination of the drug, then I titrate the dose and I push higher until the patient cannot tolerate the side effect. Then
okay, is the pain very disturbing?
Yes, very disturbing.
Very disturbing. Is it easier to treat patients with the negative symptoms rather than the positive symptoms?
The negative symptom is more like the prevention of the food care is more important because we are worried the diabetic foot ulcer patient may develop. It's not about treating the negative symptom, but the positive symptom is very disturbing. I agree with you. Not easy to treat from our clinical experience.
Is amputation a treatment of choice? Sorry, but
yeah.
for those with unbearable symptoms.
But patient may complicated with the phantom limb syndrome.
Yeah, I mean, it sounds a bit drastic. So somebody asked, what about infrared?
I'm not aware the study, but I think some patient may feel some relief because the heat generated, because patient feel warmer.
Is there a treatment of infrared?
I'm not exactly really aware, but I do see some physiotherapy have been using for.
Yeah, possible.
Yep.
Yeah. Okay, so now, do you have any more slides to share? If not, I will share.
No.
Okay, you stop the share. So I will share my this one. Okay, share.
Yeah, Dr. Anusha asked peripheral neuropathy ever go. It depends the onset and how severe, when was the onset. If early, probably there's a possibility of reversible.
Okay, so this QR code is for doctors. Use your MMA app and scan it. Okay. If it cannot be scanned, delete the MMA app and reinstall it and see whether it can be scanned or not. Okay, try that. Anyway, I'm so sorry that I didn't, I thought that you would already, when I said you agreed, I thought you would like, okay, put in your calendar. And then I wanted to remind you, but I went to climb Mount Kinabalu last week. And then today I just...
Sorry for that, because this week I have about 4 or 5 talks, so I don't know which one is it.
Oh my God.
Yeah.
Okay. So we'll